This video we're going to be covering brain injuries and disorders. First, we're going to talk about increased intracranial pressure. The normal level for your intracranial pressure is 5 to 15, and it consists of three components, which is your blood, which is 10%, brain tissue, which is 80%, and your cerebral spinal fluid, which is 10%. If an increase in one component is not accompanied by a decrease in one or both of the other components, you will have your increased intracranial pressure. The body naturally helps in two ways. The cerebral spinal fluid can be shunted to the spinal subarachnoid space, and with hyperventilation, it constricts the cerebral blood vessel, so it decreases the amount of blood flow coming in. So those are your two natural ways. If those cannot help, that is when a person is said to have increased intracranial pressure. So as nurses, what are we looking at whenever we say someone has increased intracranial pressure? One of the first signs is going to be that decreased level of consciousness. They can also have restlessness, irritability, hyperventilation, oculomotor dysfunction, vomiting, and this is usually vomiting without being nauseous. They can have headaches, and they can have some abnormal positioning. Some late signs, these are your late signs. This is known as the Cushing's triad. So the Cushing's triad are the three things that change with your vital signs. Again, your Cushing's triad. This is when a patient, you'll notice that they have bradycardia and irregular respirations, and they often have a widened pulse pressure. And remember that the widened pulse pressure is the difference between the systolic and the diastolic. They would have that decreased level of consciousness because the cerebral cortex is impaired. They could have the oculomotor because compression, which diminishes reactivity to the light, which causes that dilation. And your arterial, you're going to have the hypertension and the systolic increases, but usually your diastolic stays the same. So with that, that's how you get that widened pulse pressure, saying the systolic is increasing, but the diastolic is staying the same. So they're both not elevating up together. Again, that's going to be your late sign, is the Cushing's triad. Symptoms in children are going to be a little different, especially our infants, because the skull has not come together yet. So they could have a bulging fontanelle, increased head circumferences, so we want to make sure we're checking the size of their head. They could have a change in eating or nursing, a persistent crying with an inability to console the child, unusual or easily irritable, a change in ability to pay attention, a change in their sleep habits. They could be sad or depressed. And you will see that they will have a loss of interest in their favorite toys and activities. Infants and young children with brain injuries may lack the communication skills to report their headaches, sensory problems, confusion. So within children, it's very important for you to observe what you are seeing, because remember, those kids are not going to be able to talk to you and give you the information needed like an adult can. So nursing care, we're going to monitoring by placing a catheter in the ventricle of the brain. Obviously, this is not done by the nurse, but their pressure can be monitored by a catheter. We are preventing the increase in intracranial pressure. So we want to avoid things that are going to cause increased intracranial pressure. So with these patients, we're going to keep the head of the bed elevated 30 degrees or higher. We are going to avoid flexing the neck. We are going to try to have them avoid coughing and vomiting. We need them to avoid straining to have a bowel movement. Avoid hip flexion. We're going to avoid suctioning them. We want to make sure they have a low stimuli, and we want to space out our care. We do not want to go in there and do all care at once. We want to space it out so that we are not overwhelming them at all at one time. So with our flexing of the neck, it obstructs your venous flow. Hip flexion increases your abdominal and thoracic pressure, which increases your intracranial pressure. We want to make sure we're spacing the care so that we do not have too much going on at one time. Diagnostic tests can be done to determine what is causing the increased intracranial pressure, but nothing specifically says it is increased intracranial pressure. Another thing we want to watch is we want to make sure we're controlling the temperature in the room, because shivering actually also increases your intracranial pressure. We also want to make sure that we are avoiding hypotonic solutions and solutions with glucose, because both of those can also increase that intracranial pressure. So our nursing care, we are focusing on preventing an increase in that intracranial pressure. So we're trying to do everything we can to keep it at the rate it is or decrease it. So what can cause this increased intracranial pressure? Many different things can cause it. What we see most are your tumors, encephalitis that we talked about last week, meningitis that we talked about last week. So pretty much anything that adds fluid or an object to the brain that makes you have pressure. So tumors, they will push, they continue to grow, and they will put pressure on the brain. Adding fluids will put pressure on the brain. Remember, in adults, our brain cannot expand. Our skull keeps it from expanding. Head injury. We're going to switch over to our head injury. Head injury usually refers to traumatic brain injury, but is a broader category because it can involve damage to structures other than the brain, such as the scalp or skull. So head injury, it can be trauma to the scalp, skull, or brain. It can cause some serious source of brain impairment. Some common causes would be your motor vehicular accidents, falls, assaults, and sports injuries. Those at higher risk are young men. 2/3 are younger than 30. The next most common is your elderly, and that's from those falls. The younger men, you got to think of sports injuries, assaults, motor vehicle accidents. Major risk of brain damage from swelling and bleeding is going to lead to your increased intracranial pressure. Your traumatic brain injury is talking about damage strictly to the brain. Some common causes would be your falls, motor vehicle accident, violent, so fights or shaken baby syndrome, sports injuries or explosive blast or combat injuries. Traumatic brain injuries usually result from a violent blow or jolt to the head or the body. There are some different categories of your traumatic brain injury. You can have an open or closed. That means literally the skin in the skull is something open, or is it closed? You can have an acceleration, which is a moving object hitting a stationary head. So an example of this is being hit with a bat. Deceleration. This object, the object is stationary, but the head hits the object. So this would be an example of someone falling. Your head is coming towards the stationary object. A combination of both would be getting hit with a ball or a bat, and then you fall and hit the ground. So see there, you're getting hit with an object and also hitting an object on the way down. Rotational is the twisting of the brainstem. This is usually seen in situations of T-bone accidents. There are 3 different types. You can have a concussion, a contusion, or a hematoma. A concussion is loss of consciousness for less than 5 minutes. So nothing abnormal normally shows on your CT scan or your MRI. Signs and symptoms can be a headache, dizziness, nausea, vomiting, disorientation, blurred vision or doubled vision, and irritability. A contusion is the bruising of the brain tissue. You can be unconscious for a considerable amount of time. Your symptoms are going to depend on the size and the area of the brain. Some common signs and symptoms would be your headache, tiredness, insomnia, loss of memory, difficulty concentrating, trouble speaking. They could have hypotension, a rapid, weak pulse, shallow respirations, a loss of consciousness, and even pale, clammy skin. Here you could have a decreased eye movement, motor function, and an elevated intracranial pressure. And all these have poor outcomes such as brain damage or death. X-rays, some things that they can do would be an X-ray, and this is going to rule out any kind of fracture. A CT and an MRI, this is going to check for any bleeding, shift in the brain tissue, and look for any edema. With this, you can also have amnesia, which is the inability to recall what happened. So let's think for a second. How could we prevent head traumas? So thinking about what causes it, we've already talked about. So take a few things. What would you think could prevent head trauma? Wearing a seatbelt. Using approved car seats for children. Want to make sure we're wearing protective headgear. Making sure that we're not drinking and driving. Controlling our alcohol, because you think about young adults, it is sometimes seen in bar fights. So just learning to control our drinking habits. For the elder generation, we're going to look at making sure we have no rugs. We're going to try to prevent those falls because that's where we see it in our elderly, or more falls. So anything we can do to prevent them from falling. A hematoma is the collection of blood. It can occur with most severe brain injuries. There are different types. It can be an epidural, a subdural, or an intracranial. Symptoms may be delayed until the hematoma grows enough to distort the hernia of the brain or show signs of increased intracranial pressure. Size is less important than the progression of the growth, meaning how fast it is developing. So I'm not so much worried about the size. We want to know how fast is it developing. A subdural hematoma is usually a venous bleed. The following increase the risk for a subdural hematoma. Patients that are on anticoagulant medications, people who have long-term abuse of alcohol, recurrent falls, repeated head injuries in the very young and the very old. Some common signs and symptoms would be confused speech, difficulty with balance or walking, headache, lethargy or confusion, loss of consciousness, nausea and vomiting, numbness, could possibly cause seizure activity, slurred speech, and visual disturbances. In infants, you could possibly see those bulging fontanelles, feeding difficulties, generalized tonic-clonic seizures, high-pitched cry. You will see an increased head circumference, increased sleepiness or lethargy, irritability, persistent vomiting, or you could see a separated sutures. An epidural hematoma is between the dura and the skull. It is usually from a skull fracture. This is usually an arterial bleed between the dura and the skull. There can be a sudden loss of consciousness or a change in pupils, rapid deterioration, and this is an extreme emergency. This can be from skull fractures lacerating the meningeal artery between the dura and the skull. This causes rapid pressure on the brain, which is some of those signs and symptoms of loss of consciousness. They could possibly have loss of consciousness at the injury, then recover for a brief period, and then symptoms start back again. That's because of the rapid cerebral spinal fluid absorption and a decrease the vascular volume in the brain. The intracerebral is the bleeding within the brain. This is usually from an open or a closed head injury or a cerebral vascular conditions. such as a ruptured cerebral aneurysm. Here are the three different types of hematomas in a picture, so you can kind of see what area that I was talking about with each of the different hematomas. Those at risk are children, especially 0 to 4 years of age. This is because they are learning how to walk, so they are falling a lot more. Young adults, especially those between the ages of 15 and 24, and adults 75 years and older. Interventions that we're going to focus on would be maintaining adequate ventilation and airway management, keeping the head of the bed elevated to 30 to 45 degrees. We're going to maintain neurological vital signs, notify the RN and MD or healthcare provider at the first sign of deterioration or improvement. Avoid activities that can cause that increased intracranial pressure, which we've already talked about. Want to make sure we're monitoring their temperature. Prepare for intracranial monitoring system. We're going to administer medications as prescribed, and we're going to put them on seizure precautions, which we will talk about later. Next, we're going to talk about brain tumors. This is a growth of abnormal cells. Primary tumors arise in any tissue of the brain, where secondary tumors are a result of metastasis from other areas. All eventually result to death from increased intracranial pressure as the tumor grows, unless they are treated. These are classified by being number 1, if they are benign or malignant. Number 2, depends on the cells that are involved. And number 3, the site of the tumor. Usually the signs and symptoms, fatigue is usually the first sign. That is followed by headache that is more severe upon awakening. Vomiting, not associated with nausea. Visual changes, behavioral and personality changes, because remember our brain and our frontal lobe kind of controls all these things, so if we're putting pressure on it. Possible seizures, aphasia, and the central nerve dysfunctions. So a classic triad with your brain tumors is going to be a headache that is usually early in the morning, vomiting without nausea or warning, and swelling of the optic nerve that connects the eye to the brain. Those are your classic triad of a brain tumor. Some interventions, we're again going to keep the head of the bed elevated, possible steroids, radiation, and chemotherapy, which we talked about last semester, and we're going to have to possibly look at surgical removal, which is a craniotomy. Radiation is usually external beams, 5 days a week for about 6 weeks. That's the normal. Chemo doesn't pass the blood-brain barrier very well, so it's usually need a very high amount, which the other body systems can't handle, so chemo is very rarely used for brain tumors. MRI has the clearest view, so an MRI angiogram is you can see what the blood vessels are around the tumors. Emergency surgery may be needed to reduce the pressure of the brain depending on how extreme the tumor is, how fast it grew. Some different surgeries are Burroughs, which is an opening into the cranium made with a drill. Craniotomy refers to any surgical opening in the skull. A craniectomy is the removal of any part of the cranial bone. And a cranioplasty is a repair of the bone or the use of a prosthesis to replace the bone. Those are some different types of your surgeries. Here are some different images of how they would do a Burrough. So your first, you can see the ones that were the hole. There's a little drill that they use, and they literally just drill it through the skull. The other one is a craniotomy, which they are actually cutting open the brain or the skull. So surgical care, we're going to have some pre-op and post-op information. Pre-op, we're going to have a baseline neuro assessment. We need to make sure we know what their current baseline is. We want to help manage anxiety. We want any hair will be shaved. We're going to do that before, and we're going to make sure this is usually done in the surgery room. The hair will be shaved usually in the surgery room, but we obviously want to talk to them beforehand so they know what to expect when they come out. Afterwards, they need to expect that there will be facial swelling. If we can visit the ICU prior, that can get them their anxiety down a little bit when they know what to expect. We are going to administer an IV or catheter if there's ordered. Anti-embolism stockings, because surgery can take a while. My mother had surgery and she was in surgery for 12 hours whenever she had her brain tumor removed. Post-operatively, they're going to do a neuro assessment usually every 15 to 30 minutes. The time will increase as obviously they increased their stay. CT scan will be done to make sure to see what was left if they got all the tumor out, make sure there's no bleeds. We are going to obviously monitor our dressing changes, watch for an infection, help with self-image. Now you could barely, my mom has really thick hair, so you could barely even tell that she had where her incision is still to this day. We're going to monitor for increased intracranial pressure, and we're going to monitor for a fever. That also goes along with that infection. Lastly, we're going to talk about skull fractures. The first type is a simple, which there are few, if any, signs and symptoms, usually heal without complications. Some signs and symptoms could be a headache, and other symptoms are going to depend on the area of the brain where the skull fracture was. Next is your basilar, which is at the base of the skull. Your signs and symptoms are going to be leaking of cerebral spinal fluid. They could have raccoon eyes and what they call battle signs. So if you're looking down here at your picture that I have added, you see down here the raccoon eyes. It looks like two black eyes. The battle sign or the bruising down by the neck. And to tell if you have leaking of the cerebral spinal fluid, you are going to have either from the nose or the ears, you will see what they call a halo sign. With this halo sign, you're going to have red in the middle and then pale yellow ring around it, which I show you on the next slide. So here's how you can tell the cerebral spinal fluid. If you see red in the middle and then how it gets lighter to a yellow ring around the edge, that is showing that they have cerebral spinal fluid leaking from either their ears or their nose. This can also be done by having a glucose test completed.